So we are going to record today's event, so this will be available for people afterwards. But first of all, I'm Jeremy Oddie. I'm the Director of Outreach and Education with the Wisconsin Parkinson Association. Welcome to our Wednesday webinar series. We are excited to offer these options during the winter months when it's maybe a little too cold, a little too snowy to get out. This gives you a chance to learn a little more about Parkinson's disease and best how to manage it. If you want to learn more about us, you probably registered through our website at wiparkinson.org. Please go there to learn more information about us. And then this video will be posted on our website, hopefully by the end of the day, worst case by tomorrow. So with that, I'm going to introduce our speaker today. He's going to talk to us about fall prevention in relations to Parkinson's disease. His name is Muddassir Mohiuddin from Therapy at Home. He is a doctor of physical therapy. I'm sure there are other things I'm not covering, Muddassir, that you can tell them about yourself. But I'm going to hand it off to you. And if you want to do your screen share, show the presentation, we'll go from there.
Awesome. I'm going to set up my screen and we'll dive right in. All right. So my name is Muddassir. Thank you, Jeremy, for the introduction. I am very privileged and honored to be here today to do a presentation on Parkinson's and very specifically fall prevention. When I got this topic, I want to give you a little bit of background on it. If I really had to put this, I could have made this presentation about 2 slides and ended it. And I'm always kind of looking at the research. What is research telling, and how can we kind of have a different perception and looking at things in a different perspective that's going to help us change our mind towards fall prevention. That's the route I went. So I'm not going to bore you with the details of the research and the studies and how they came up with certain things. Definitely, if you want to, I can pass on those articles, which I am using this presentation for. So you're going to start off with the overview of the press. So here's what our objective is, what is our take-home message. So the way we're going to address this is, first, we're going to talk about what are the fall risks associated with Parkinson's. So having that Parkinson's, we already have certain risk factors that are likely going to increase the risk of falls. We're going to start there. Then we're going to talk about what is the impact of falls on quality of life. So yes, we know there is a fall risk. So what is the impact that these fall risks are going to happen on quality of life from a first person's? And I'm going to be referring we, because I really believe that this is a collective effort amongst all, from patients, providers, doctors, nurses, each and organization. It's a collective effort. So we're going to be referring myself and all of us as we, as I talk during the presentation. After talking about the impact, we're going to talk about how does the disease progress and how the risk of fall increases or decreases. What are the risk factors associated with frequent fallers? So based on research, they have characterized, there are people who fall and there are people who don't fall. And then there are frequent fallers. So we're going to talk about what research says and the impact of anxiety and depression on fall. This is post-pandemic. I hope I can say that term right now with a variant out. But, during the pandemic and after the pandemic, there has been a lot of talk about mental health. And there's a big impact of mental health, anxiety, and depression on fall. So we're going to talk more than I would, in more details, what is the impact of anxiety and depression on falls. And then we're going to look at, hey, what can I do? Now I know all these risk factors. What practical steps can I do about preventing falls? So that's where we're going to, that's basically the overview of the presentation. And we'll dive right in, starting to talk about fall risk. So there's a term I want to define before we dive in. Fallers refers to people in the articles that I've referred to, people who frequently fall, and there are non-fallers who may just have one fall a year. So that's how they define. So, I want to always start on a positive note here. So, there's a lot of research done on fallers, but I really wanted to know more about non-fallers, and I've not done research, nor I have tumbled on any article talking very specifically the characteristics of non-fallers. But just probably a presentation for another day. But there's a group of people, approximately 30% of people with Parkinson's disease do not fall. And we need to learn more about it. That's another presentation. So as we know, people with, we are at a risk of falling 2 times more likely than any other people. When we are comparing this, right now we're comparing the data to elderly, 65 and plus. So the rate of falls is anywhere from 37% to 87% of people fall. I know that's a very, vague number, but if I refer back to the original article that I'm referring to, there's about 70% of people with Parkinson's fall. So within the falls, there are fallers, there are recurrent fallers, where 70% of the people fall recurrently, and then there is 13% of people who fall on a daily basis, and out of that, they also fall multiple times during the day. So why do people fall when they have Parkinson's? I think we all know the answer. That primarily goes back to the motor symptoms and non-motor symptoms. As we know, the decreased flexibility, slow movement, bradykinesia, slow movement, freezing of the gait, and postural changes. Those are the things that are, from a motor perspective, causing the falls. And from a non-motor perspective, we have low blood pressure, urinary incontinence, visual changes, fatigue, and lack of sleep. Those are the other non-motor symptoms that causes people to fall. So I want to start with the basics. So we know why we are at fall risk when it comes from a disease perspective. Now we're going to talk about impact on quality of life. So what happens if you fall? And it's very, this is something taboo. Like, I really think it's still a taboo. People don't want to talk about it. I think we have to seriously talk about the impact of falls on our quality of life so we can do something about it. It's a, if we don't know what is the impact, then we're not going to take the necessary steps in order to make sure that we don't fall, or in order to make sure that we are decreasing our fall risk. So the impact on quality life, increased morbidity, that means the increase in the suffering of the disease and disability. So people who fall will suffer more and will have more disability. And people who do fall, they're going to have fear of falling. And we're going to talk about fear of falling in a greater detail, but that really does make sense, right? If you fall, you might develop a fear of falling. You might have decreased mobility because you're fearful of falling, that you might prefer not to move as much. And again, overall, as the disease progresses and your mobility further declines, you're probably isolating to yourself. You might just be isolating yourself to your home and very small circle and small network. And there is anxiety that comes after fear of falling. And you will start to lose your independence. You might start depending on a caregiver or a significant other to help you with activities of daily living. The impact is also having a hip fracture, having head trauma, contusion, and lacerations. So basically injuries that might happen because of the fall. And it may result in hospitalization, admission to nursing home, or assisted living. And there is a big financial burden. On average, it might cost you $50,000 to $70,000 for a person to live in an assisted living or a nursing home. These are the statistics just based on these are not statistics. This is based on my personal experience, the amount of cost that someone in my family have paid to live in assisted living. And that's the huge economic burden. And also it may result in death. Well, knowing that these are very, if I look at these risk factors, you know what? I want to be mobile as long as I want to be. I want to be independent as long as I want to be. I don't want to live in a nursing home or assisted living. I don't want to spend that kind of money living in alternative living facilities, but I have to do something about that, right? And I don't want to die, right? Not at this time. Our destination is death, right? So we need to do something about it. So there's very serious consequences of falling, and there's a lot that we can do. So before we do that, we're going to talk about what happens. So we talked about why Parkinson's disease, why are we at higher risk of falling? We talked about the consequences of falling. Now we're going to talk about how, as the disease progresses, what happens, right? As we all know, as the disease progresses, there will be more motor and non-motor symptoms. Again, decrease in flexibility, slow movement, freezing, imbalance, all of those things increase, and increase in falls as the disease progresses. You might be utilizing a assistive device such as a cane walker, a U-walker, wheelchair, a motorized scooter. So basically, and you might be requiring more help in self-care. There's increased assistance for activities of daily living, and cognitive changes and visual impairment. So as the disease progresses, the quality of life decreases, the risk increases, and there are some cognitive and visual impairment that impacts. So those are the things that happens automatically as the disease progresses. Now, now we are transitioning to the risk factors associated with frequent fallers. So this is based on the article. It's a meta-analysis. So what that basically means is, rather than looking at one research study that may have anywhere from 100 to 200 people, they combine numerous studies together and they analyze the data, just the data. And the purpose of the study was to identify what are the risk factors associated with frequent fallers. You might feel like at this point, I am repeating myself. So I do want you to, rather than disengaging at this point, let's think about a person standing in the center, and all of us are looking at this person falling. So, somebody might be looking at this person from the front, somebody might be looking at this person from the back, somebody might be looking at from the right and the left, somebody might be looking at this person diagonally from the top and the bottom. So what we are trying to understand is that how fall risk in Parkinson's impacts people, and looking at a different perspective. So a lot of these things are going to repeat, because we are talking same thing, but from a different angle. So that's what it is. So we're talking about the same thing, fall risk, but we're talking from a different perspective. Now we're talking from a perspective, what are the characteristics of people who fall frequently? So they have fear of falling. We're going to talk about that in greater detail. They are going to have a high risk, reduced mobility. We already talked about that. Reduced physical activity. They're going to have freezing gait, this is part and parcel of the disease. Balance impairment, there's postural changes, part of the disease. Cognitive impairment, as the disease progresses, we know we're going to have cognitive impairment. One thing to point out here is they notice that people who fall frequently have longer duration of the disease. That makes sense. As the disease progresses, in the middle to late stages, they're going to have more impairments, and that's why they're going to fall frequently. And then they will be on a higher dosage of levodopa. That's also a risk factor in itself. So these are the characteristics of people who fall frequently as the disease progresses. The next thing we're going to talk about, you have a fall, right? Now we're going to look at fall and fall risk from a perspective of fear of falling. So once you fall, you might build a fear of falling. So what are the risk factors? Being a female gender is a risk factor of having a fear of falling. And obviously it makes sense. If you have fear of falling, you'll have history of falling. And the fear of falling increases as you have injuries. For example, you had a fracture, you had a contusion. And typically people who have fear of falling, they tend to rate themselves lower on their overall health. There's that mental perspective of it, mental perception of their own health. And then they tend to be of lower socioeconomic status, and their quality of life, they have decreased quality of life. And people who also have fear of falling, they might be on multiple medications. They'll have balance impairment, gait and mobility deficit, requiring more assistance with activities of daily living. They have social isolation, sedentary lifestyle, depression, anxiety, and they may leave alone that is directly related to possibly isolation. So if you see now, we're starting to repeat the same thing over and over. And the purpose of doing it is looking at fall risk from a different perspective. So from a perspective of fear of falling, there's a lot of common things between fear of falling, between people who frequently fall, and also the disease progress itself. The next thing we are, just want to clarify here, everything here is very specific to Parkinson's disease. We are not talking any generic information here. We're not just talking frail, elderly, or older people. So other risk factor is anxiety. As we talked about, you might have a fear of falling, and that might become into an anxiety issue, right? So what are the characteristics of people who have anxiety due to falling? So they might be female, they might have a younger onset, they might have postural instability, they might have morning dystonia. Dystonia is different from tremors. Tremors are more rhythmic, and dystonia would be one movement here, one movement there. It will have a different frequency. They might have anxiety. They might have previous anxiety, psychosocial stress. That means basically they're stressed about how people might look at them, and they are stressed about their social status itself. They might have more episode of depression. They have increased motor fluctuation. That basically means their ability to function is variable. They'll have decreased sleep, decreased gait, implies they have poor gait, and decreased self-related health status. We already talked about people have their perception that my health is not good. And again, things that start to show up here is sleep, mood, loneliness. These are directly related to mental health aspect of things. So the risk factor, now we're going to look from a different perspective. So, okay, we looked at it from anxiety, we looked at it from a perspective of frequent falling, we looked at it from a perspective of as the disease progress. Now we are talking about risk factor directly related to people with Parkinson's and depression. So if you think about it, you have a fall, you have a fear of fall, you have anxiety, and you might develop into anxiety. I'm not saying this might be the progression, but it's all related. So you might see depression as well. And what are the risk factors associated with depression, right? You might see the commonality. They might be early or late Parkinson's disease. They might have history of depression. They have history of anxiety, cognitive deficit, motor disability, bradykinesia, which is slow movement, akinetic rigidity. That basically means as you begin to move a muscle, you will feel some resistance and the movement might be slow. And rest leg, basically you have that urge to move the leg. Typically people experience, and it's also painful, experience this mostly when they're resting. People who are at higher risk of depression with Parkinson's disease, they are female, younger age, they might have tremors, they have increased dosage of levodopa, gait impairment, and decreased sleep. And alexithymia, I can't even pronounce that word, but that basically means that they have poor ability to express themselves or verbally, and also express themselves from a facial perspective. So now taking, now that we talked about fall risk associated with the disease itself. We talked about fall risk associated with the progression of the disease. We've talked about fall risk associated with just what are the fall risks associated with the frequent fallers. We talked about fall risk associated with people with Parkinson and anxiety. We talked about fall risk associated with people with anxiety and depression now. So I just want to give a big picture here. For example, you might have a trigger. You might have a trigger that caused you a fall. Now you panic, now you worry. Now it becomes your belief system. And this belief system of fear of falling starts to take control. You might build a fear of falling, and then that might build into an anxiety. So there's a cyclic effect of it. And that really takes up such a big mental stress on your brain. you do not have enough power to consciously think about yourself when you're walking and pay attention to things. So there's such a big cognitive burden on your brain when you develop anxiety of falling and fear of falling. I'm so worried, dead worried that I'm going to fall, and I'm not confident about myself walking. How can I pay attention to my surrounding? How can I consciously lift my foot? How can I straighten up my posture? How can I think about taking those big steps, right? So that's what I want you to understand, that this could take so much brain power out of you, you might not be able to focus on your gait itself. And then the big picture, depression, right? So you might have, we talked about fear of falling, if you're right here, fear of falling. And then that might become into an anxiety. You might stop yourself from moving frequently. You might not engage in physical activity. You might be more dependent, and that might result in physical weakness. At the end of the day, it will result in social isolation and possible anxiety, depression. The difference between depression is very specific, and anxiety, for example, I could be anxious about falling. I could be anxious about, heights. So, and also phobias are also a part of anxiety. Anxiety is a symptom, and depression is a very specific disease. So I just want to give that perspective. So we've learned a lot, and all these talk has been very, in a way, negative, I want to say. But at this point, what I want you to do is, consciously think about all these risk factors we have talked about. There are a lot of risk factors, and the disease, that as the disease progresses, the risk factor of frequent fallers, the risk factor of anxiety and depression. Now, at the end of the day, you're still the captain of the ship, and you can manage it. And we're going to look at the risk factors, and we're going to talk about how can we change or modify these risk factors so we can win this game. All right. So if you look at this slide, this was previously presented, where this was a research done to identify people who are frequent fallers. So if you look at the list, I'm going to go back here. So this was the risk factors identify people who frequently fall. These were all the risk factors. Now I have color coded it. And if you see, everything with the exception of cognitive impairment and long-term disease is a modifiable factor. So what I'm trying to tell you here is, you might be at a risk factor of being a frequent faller, but 87% of the things are modifiable. There's something you can do about 87% of the thing. That's big. That's very big. There is something you can do about fear of falling, reduce mobility, reduce physical activity, freezing gait, your balance impairment, higher dose of levodopa. If you're taking high dose, you can modify all of this. So even though these are risk factors, there's a lot that we can do. And now, earlier we talked about fear of falling, right? People who have fear of falling, they build up. If you look at this, 60% of these things are modifiable. You can, if you're taking multiple medications, you can work with your physician and try to decrease. If you have balance impairment, you can work with a physical therapist or start an exercise program. You can improve that. You have great impairment, you can work on it. You have difficulty with activity of daily living, you can work on it. Social isolation, you can work on it. Wisconsin Parkinson's Association, a lot of activities around promoting social interaction. There's something you can do there. Having a sedentary lifestyle, you can do something about that. So basically, the take-home message from this slide is, there's 60% of the risk factor, you can work on it. Yeah, we cannot change the gender. We cannot change that in the past we have fallen. There's nothing I can do about it. If you have an injury, there's nothing I can do about it in the past. All of us are aging. We cannot do anything. I really feel like I misclassify this poor self-related health. Your perception of your personal health can also change. So again, that might be 62% of things that you can change. Lower economic status, it might be difficult to change that, but it's possible. And decreased quality of life, again, I think it should have went on the right side here. So 65 to 75% of the risk factors you can modify it from fear of falling. Now, we are talking about anxiety and depression. What are the risk factors? We talked about the risk factors already, but based on, basically everything that you see in orange, you cannot change that. That's a non-modifiable risk factor. Anything that you see in teal bluish color, you can modify. From that, 55% of things you can modify to improve your anxiety related to falls. And from the depression, the one on the right, if you look at the modifiable factors are fewer when it comes to depression. There are 42% of things that you can modify to have a decreased impact of depression and at the end of the day, not falling. So we talked about all these risk factors, and now we have a very positive perspective of falling. And I'm really optimistic about this. There's so much that we can do about modifying those risk factors versus non-modifiable. And now it's the time to take action. So, and the question is, what is the action? And you've already heard about this numerous times, and everybody is at a different stage at a different time. You have to customize and tailor your approach towards where your disease is, what process of the disease you're in, how is your disease progressing, what medication. So you have to personalize this application of how to decrease your risk of falling. One thing people have done, and I think it's absolute disservice, is like you look at the disease and then you look, hey, this is what's going to happen automatically. There's nothing I can do. And that's a very wrong perception. There's a lot you can do about it. And it does take a proactive approach. A lot of time we tend to look at healthcare professionals, physicians, doctors, therapists, counselors. We look at other people and say, hey, how are you going to help me? And that's a wrong approach. What I will highly, highly recommend before we dive into the next portion of this presentation, as I said, you're the captain of your ship, and it is up to you where you want to drive this. At the end, we have the same destination. With Parkinson's disease, without Parkinson's disease, the destination for all human beings is the same. So you're in charge, and let's look at it with a positive perspective and how we can take it to the next level. So the big question is, what can I do? And I am very positive. You have seen this numerous times. Physically active, being physically active, exercising, social engagement, medication management. So somebody might ask, what is the difference between physical activity and exercise? Physical activity is just, for example, I stand up and go to the bathroom. That's a physical activity. And exercise is I, roll for 40 minutes every other day. So that's my exercise. I know that's what I'm going to do at a specific time, specific duration. So with this planned, structured activity is exercise. Social engagement, there's a lot of ways of social engagement. This is the greatest time for social engagement. It's a holiday season. So it's a lot of social engagement around it. And how other ways can I engage with the Wisconsin Parkinson's Association or with my local church, and different ways that you could do to engage and keep yourself busy, positive busy, not just busy, mindfulness busy, not subconsciousness busy, such as staying on the phone and just going through things, just, mind, body, and soul presence in social engagement. medication management. Definitely an ongoing effort, talking to your physician and talking to your pharmacist, seeing how you can take fewer pills. And it's a medical decision based on your neurologist, your primary care, and a pharmacologist, pharmacist. So as we know, there's a lot of very strong evidence that proves that exercise helps with all of these things: flexibility, strength, mobility, endurance, and balance. At the end of the day, exercise is something that's going to help you with most of your motor symptoms. Indirectly, it also helps you with some of your non-motor symptoms, and it also helps you with your cognitive impairment. As you know, we talked about, as the disease progresses, there might be some cognitive decline. But again, if you reflect on it, if you're anxious and if you're depressed and your mind power, so much of is going on worries and the psychosocial aspect of the disease, you do not have the brain power to focus on life and quality of life. So going back to the same thing again, like gotta get over the fear of falling, gotta get over anxiety, depression, and getting involved. That's the key. And so these are basically research showing that, you know, as you participate in exercise and increased exercise and physical mobility, your disability declines and your function improves. Again, more evidence to show that exercise works. So at this point, what I want to do is, and I know people are probably trying to look for solutions. You know, this is very generic, and I told you, you know, it needs to be, because we know the disease now needs to be personalized based on you. So if I like to, you know, the question would be, hey, where should I start? You should start what you love to do. If you love to bicycle, then find a way how to bicycle. If you like to run, find a way how you can do it. It might evolve and it might change, you know, and it's absolutely possible. If you like to do crocheting, if you like to do any physical activity that keeps you occupied, and it keeps not just occupied, but that has the benefit of increasing your dopamine and improving your quality of life, and doing it conscious will have a positive impact. You have to do it very mindfully and consciously to have a positive impact on your quality of life, and also decreasing the fall risk. So from a disease progression, if you're in early stages of the disease, when you are diagnosed and you have fewer disability and fewer motor symptoms and non-motor symptoms, this is the great time to, you know, do an inventory check and say, what do I absolutely love to do? What can I continue doing it? Or is this a good time to look at a new skill that I could develop that's going to help my mind, body, and soul? It's a good time to discuss. You know, some people do not have, you know, early on, you know, there are a lot of people who have young onset of the disease, and they might not, because they're so busy in academics, raising a family, they have a hobby to explore. But this is also a good time to find out what I could possibly continue to support myself and focus on doing a hobby that's going to have both mental, physical impact on me. So some of the programs that, you know, a lot of people with Parkinson's talk about is LSVT, Big and Loud, Parkinson's Wellness Recovery, Rock Steady Boxing. These are just few avenues. You can, you know, these are some ways of doing it, but you can choose your own and make your own destiny. And obviously, this is a great time to educate yourself and your family. And you have to have a working long-term relationship. You can't just see a physical therapist once and be done with it. You need to have my recommendation with the early, once you're done with the whole program, check in 6 months, 1 year at the early stage of disease. As the disease progresses, you know, as we know, the motor movement becomes more difficult. You might be falling often. You might use some assistive device. You might require more hands-on therapy, especially when you have more rigidity. You have more postural changes to help kind of maintain that this is also a time, for example, if you like to bike and now you cannot bike anymore because your balance is bad, also a time to invest in equipment such as New Step or a TheraCycle or an e-trainer, depending on your interest. Not, people trying to sell one thing versus other. You need to absolutely like it, that you're going to do it. That's when you want to invest in things, because now you might not be able to go out biking. Staying physically active, that means not having that fear of falling, not being anxious of falling. So for example, yeah, I did my exercise, daily exercise, but now I'm watching TV. I'm not going to just sit here for hours together. You want to get out, walk around the house, be physically active. Exercise is just not take it and done with it, but you have to be physically engaged throughout the day beyond that, beyond just doing physical activity. I'm not going to do anything. That's not going to work. You have to still stay physically active. In the later stage of the disease, the movement may be quite limited at this point, and maintenance therapy is often necessary. What a lot of people are probably not aware of, if you are a Medicare beneficiary, especially if you have Parkinson's disease, you are entitled to have something called a maintenance therapy. That's an ongoing therapy. That you can see a therapist on an ongoing basis, as long as you have a set plan of care. There needs to be a reason and what you're doing to maintain your abilities or slow the decline of the disease. And I would definitely recommend you start more during the middle stage of the disease versus latter stage of the disease. Now I'm going to talk about some practical tips, how to decrease your fall risk. And basically, if you are walking, you want to at least keep one hand free, so you have something to, if you have a trip, you can hold yourself somewhere and prevent yourself falling. Never carry two things. I definitely recommend, as your disease progresses, carry a backpack or a fanny pack that's going to help you carry stuff. Especially be conscious getting in and out of the car, getting in and out of the house where you need two things to carry. Definitely when you're shopping, you always have a shopping cart, so you don't have to carry things as you're shopping, so your hands are free. Keep at least one hand free. We talked about that. Use your backpack, fanny pack. One thing that requires a conscious effort is when you're walking, especially, you want to swing your arms from the front to the back, and it does require conscious effort. As the disease progresses, it absolutely requires conscious effort. It does become automatic at a certain point, especially if you have cultivated this in very early stage of the disease. It will become an automatic thing that you are going to continue to swing your arms. But it might require a conscious effort in doing so. And also, as we know, the freezing gait, consciously, lifting your foot and taking big steps. Again, when we talk about navigating turns, you want to think about think about yourself. You cannot just take sharp point turns. Think about taking a U-turn so you have enough room to turn. I would definitely recommend not to wear rubber or grippy sole shoes if that is impacting. You want to wear a shoes that supports your feet and also has good traction, but it should not impair you from, it should not stick you to the ground, so you can easily lift it and take steps. When you're frozen, visualize that you're taking a step over an object. That definitely helps. There are technologies. Sometimes people attach laser to their cane or a walker so that they visualize that laser and they take big steps. That does not only help with the freezing episode, but also helps with taking bigger steps if you, put it in a way where it's going to, will force you to take a bigger step. Again, considering an assistive device, canes, walkers, U-walkers, they're different walkers. Not every walker is meant for it. It's very specific and tailored to a person and their need. Motorized scooter might be an option, and also wheelchairs are an option. Performing, the biggest thing is performing a home safety assessment And there are lots of resources out there, and you probably already heard about them in regards to what to do. Usually a physical therapist, if they do come home, they will assess and make sure your home is safe for your safe mobility. And this is my concluding slide here. I want to make sure that we leave enough time to answer questions. So the big take-home message is, focus on, if you do have fear of falling, that's something might translate into anxiety and depression. And it is very important that you address it. And the only way to address it is not, medication is an option, but you actively engaging in physical activity, engage in exercise, social engagement, medication management, all of these is going to help you at the end of the day, having fewer falls, having a better quality of life, and having a positive outlook on your life. And if you even think about it, I'm going to expand a little bit more on anxiety and depression. Anxiety and depression are so dopamine, they decrease the amount of dopamine in your brain. And then you're taking medication to have more dopamine so you can function properly. That has a negative impact. So, and then you're trying to increase your level of dopa and it's not helping you. So these are key things, talking about having a social support, having those conversations with your significant other, having conversation with your family, extended family, so you feel like you have the support system in order to have a positive outlook, and also building friendship with people with other people with Parkinson's disease, being actively engaged in Wisconsin Parkinson's Association. Those are the things that will get you to where you need to be and have a positive outlook and a better quality of life. Thank you. I think I'm open for questions at this point.
Perfect. Muddassir, if you want to stop screen sharing, I will allow people now to join us. So I'm going to start just allowing people to talk. So if you have questions, you can do that in the chat area, or right now your screen is available. You are muted. So I need you to change that. But beyond that, you are allowed to talk right now. While people are thinking of questions, one thing I will ask you, Muddassir, you work for Therapy at Home. Can you explain a little bit what that is and how people would contact you if they were interested in learning more about your services?
Yeah. So we provide in-home physical, occupational, and speech therapy for anybody who needs service at home. The way you can reach out to is as simple as calling us. That would be, I can put it in the chat, or looking on Google Therapy at Home. That's how you will contact us. But I'm going to drop the phone number and email address of as well.
Perfect. All right, and then if any of you have questions, feel free to speak up and ask.
Carload price is just $25, and every car gets a holiday gift bag. Get carload and skip the line tickets at winterwonders.org. Winterwonders.org.
Some of you do have your TV on, so if you want to turn that off, we can hear your TV.
They can't get it.
Jason Caulfield, Sunday's Deli Chef.
David is walking in the store, seeing what produce.
There we go. Any questions in the chat? Any questions for Muddassir on fall prevention?
Yes, I have a question. I'm not sure I got the point, so I probably just want you to repeat it. Did you say that medications given to manage anxiety and depression also tend to impair cognitive functioning? And I'm wondering if, first of all, did I get that right? And secondly, is there anything that can be done about that aside from speaking with your physician and trying to make out a treatment schedule that minimizes these problems?
So a lot of medication, the psychotropics, people who are on anxiety and depression medication do have fall risk associated with it. When I did suggested you to do a do a review of your medication with your physician. That will allow you to say, like, you need to, like, just because you started a medication, you need to kind of monitor it, how it is helping you, and can you, like, it's a discussion between yourself and a doctor. You cannot just get off any psychotropic medication cold turkey. It has to be a discussion and slowly get off it. And then again, if it's something, that's the learning process. This is positively impacting me, this is negatively impacting me. Do I need to stay on? And again, my biggest recommendation is social engagement. Having, you don't need to feel that you're dealing with the disease by yourself. There's a lot of support. We need to talk. And a lot of times people don't want to talk. If, it's the feeling, we are humans and it's normal to talk, especially with our loved ones and people who are experiencing the disease with your providers. So you feel, have the sense of community, and it takes a village.
Is there any relationship between the amount of dopamine you take and your risk of falling?
Yes, there is. But again, I don't want to be told, as this therapist said, that that's a conversation between you and your doctor, because that's a process that you might, there are some patients, they sometimes stop responding to dopamine. So what physicians would do, they'll take them off completely. And and then slow, in a tapered fashion, they would do that. And then a tapered fashion, they'll bring back. That's a neurologist's decision. And they might, again, there are other medications that help to supplement, and that's beyond my scope. But don't go and tell your physician that a therapist said that dopamine increases fall risk. It does, but you have to weigh the risk and the benefits.
And if I can step in, Muddassir, from the
definitely.
WPA perspective, I think you said it very well. I think it's a good thing for everybody to remember, because both questions have been medication related. Everybody's Parkinson's disease is different, so everybody's medication treatment is going to be different. So what might be too much dopamine for Terry is not enough dopamine for John. And I think that's the one thing we always try to recommend people. Every physician I've ever worked with Parkinson's always says, if you know one person with Parkinson's disease, you've seen one person with Parkinson's disease, because everybody's symptoms, how they react to medications and things like that are extremely different. If you have concerns, and I think Muddassir said it very well, is if medications are added and now you're seeing falls or cognitive or other issues, you need to be an advocate and track those and talk to your doctor immediately, and make sure you're staying on top of those things, as well as your care partner. But there is no, unfortunately, to Terry's question, there is no magic number of, okay, if you take 5 pills, that's too many. If you take 3, that's right, because 3 may be perfect for half the people on this call, and 5 may be just enough for the rest of the people. And that's where you have to talk to your neurologist much more efficiently to figure that out.
Absolutely agree with you there, Jeremy, 100%. And in that regards, there was an article that I wrote in the November magazine. Was it December or November?
We call it the Winter Magazine, but yes.
The Winter Magazine. Please do refer to it, because there are lots of tips on it. Very, how to talk to your physician and how to work with your caregiver. That will definitely help you. It's your disease. These medications are going in your body. You need to be the person asking questions, or your caregiver.
If you're on our mailing list, this is, oops, I have my background board so you can't see it. Give me 1 second. This was the copy of the magazine that just went out about a month ago, around Thanksgiving. So if you don't have this, it is on our website, or you can call, email us or call us at 414-312-6990, and I can mail you a copy of that has Muddassir's article. Other questions? All right, we'll give it one more chance. If anybody has questions, here's your chance to ask them. You can type them in the chat. I will read those out. But if you have other questions, now's your chance to ask. We'll give everybody a couple seconds to think about it.
If you don't have questions, and I just felt like there's one additional thing I wanted to mention is, there's, as the disease progresses, there's a very pronounced on time and off time. What that means is your on time implies your medications are working very well and you don't see any motor symptoms. You don't see difficulty with your gait, walking, standing, and all of that. The off time is when the medication don't quite work well, and you might be at more risk of falling during your off time. So knowing your body, knowing your on and off time, you need to schedule yourself. This is a good time for me to go to the exercise step. This is not a good time for me to do that. This is a time that I need to call for help from my significant other caregiver to go to the bathroom to decrease the risk of falling. Those are a couple other things I thought I would add value to your to this topic.
What if there's
Urinary incontinence, how does it increase fall risk? So people have different kind of urinary incontinence. For example, people have urge urinary incontinence, that they have an urge, they gotta go right away. So they might be trying to rush to the bathroom, and if there is a off time and they're trying to do it, they're increasing their risk of falling. Alternatingly, you need to have the love. You need to know your own body and understand that, hey, our incontinent products are there just as the emergency. If I do have an accident, hey, I'm not going to have to change a whole set of clothes, but I can just change my incontinent product and I'll be fair. So it's like the challenge comes at when people think, they just think that it's a solution. It's a temporary solution, and it can become a permanent as the disease progresses, but you need to utilize it the way it intend to be utilized. Just don't give up and this will directly goes back to physical activity. Hey, I have my incontinent product depend on, I'm not going to go to the bathroom. It's just, so now that's indirectly impacting you negatively because you're decreasing your physical activity.
I'd like to ask another question about the on and off times. I don't seem to have any particular on or off times that seem to stay the same all the time. For example, in the morning when I get up after 11 hours with no medication, I'm every bit as good or as bad as I am after medications. Doesn't seem to make any difference at all.
So you have not seen that in your disease process yet. Is that
No.
what you're saying?
No.
That typically,
My
so
mobility
again,
is getting worse and worse.
I don't want to say that it's going to get worse and worse, but it's
Mine is. My mobility is getting much worse.
okay. That is definitely a discussion with your physician, and they need to know the information very concisely so they can also tailor your medication. It's a trial and error to figure out what is going to be best optimally work for you and your body. Jeremy, you can have additional comments, please do.
Yeah, I would agree with you wholeheartedly, Muddassir. I think that is 100% something, Terry, you should be talking to your doctor about, because you should see noticeable changes with the medications, with your on and off times, and your ability to have greater movement. And if you feel you're seeing absolutely no changes from morning to night, despite the medications, you want to make sure you're talking to your physician about it. The other caveat I would put out there, and I don't want to dig too deep, is if you're seeing a movement disorder specialist, and that's a neurologist who has a year more training, that they specialize in movement disorders such as Parkinson's disease, they would have a better understanding of what's going on versus maybe a family practice doctor or a general neurologist who is not a specialist in Parkinson's disease, and then really get that looked at and talk to them. And they should be seen when they do your exam and the appointment. When you go in for an appointment, they should be doing tests that show them if your mobility is getting better or worse with the medications. And if that's not happening, that would tell me you're not seeing a Parkinson's specialist, and you want to look into that. And we do have a list of Parkinson's doctors on our website that you can look at to figure out where your doctor would fit into that category. So it looks like, Muddassir, we have one more question in the chat.
Yeah, I see two of them actually. One was in the article I spoke about visual changes. Typically, people with Parkinson's it depends. I don't want to say early, middle, or late. As the disease progresses, they notice visual changes. Some people will see double vision. Some people will have blurred vision. Some people will have a different perspective of vision. I don't know how to quite say that. It's like there's a visual depth perception too. And then there is they might think an article is on the right, but they might miss it. It's a visual depth perception, I think, but it maybe not. Jeremy, help me out there. I don't know what it's called, but
yeah,
those are
usually they call this double vision or depth perception. I think the biggest one we see with falls is the depth perception, where the floor comes a little faster than you thought it was going to, or it's farther away than you thought it was, and it causes you to be off balanced.
Yeah. The question about the vertigo, yes. People with Parkinson's, some of people do experience some vertigo, dizziness, and yes, that can if you experience it because your brain is telling you that things are moving, or you're moving, or the room is moving. That's scary. Then you're trying to make a step that increases the fear of falling, and that's more that is a very challenging place to be at, having that vertigo. But the biggest thing is, again, it goes back to the primary care physician. Is it directly related to your Parkinson's disease, or this is something else impacting? For example, as a physical therapist, there's a condition I've noticed very occasionally in people with Parkinson's when they fall and their crystals in their ears are out of place. There's a simple treatment as a therapist could do it, or and fix that, or they have to do a habitual training for people with vertigo if that's what causing, which is more peripheral, not away from your brain, more in your inner ears. There's something we can do about it.
I have one more question, Doctor.
All right, we'll make this the last question then. So go ahead, John.
I have some of these visual symptoms that you're talking about, but I think they started before my Parkinson's 3 years ago was diagnosed. I guess my question is, where can I go? I don't think it could be just an ordinary, if I could use that word, ophthalmologist. Where can I go to get a thorough evaluation of my vision to see whether it is related to Parkinson's, and if it is, what kind of follow-up I would need?
It's been a while, but there are certain ophthalmologists, and Jeremy can help me out. They are very specific, working with Parkinson's disease. They have certain prism glasses, and also consider an audiologist. I would say they can rule out other things. So with certainty, you could say, hey, this is related to my Parkinson's versus this is related to my peripheral system, your vestibular and your ear part of it. And Jeremy, what are any suggestions?
No, I think you gave them the best answer, Muddassir. Is it's not a general ophthalmologist or optometrist, sorry, but there are some that do it. What we've kind of relied on is we'll reach out to the physician that you're working with and see if they have somebody they work with, because there's fewer and fewer around that specialize in Parkinson's disease. I would say, John, it's not unusual for symptoms to show up anywhere from 5 to 7 years before a diagnosis. That is actually very common with loss of sense of smell, some of the balance issues, vision, etc. But I definitely would talk to your doctor. Is this happening? He or she would have a recommendation of a optometrist that you could go that would see, is it Parkinson's specific? And it is, well, how do we treat that versus if it's just normal aging and deterioration of our vision that happens as we get older.
So should I be looking for a neuro-ophthalmologist?
Yeah.
If there is one in the area, absolutely.
Thank you very much.
Yes.
Thank
So
you.
We're about 5 minutes after, so Muddassir, I'm going to say thank you. Obviously, some great questions and some good participation. Thank you for sharing your expertise with our audience and everybody else that was here. This will get posted on our website, so if people want to see this or share it with friends or family, you can do so. But with that, if you listen really closely, Muddassir, you're getting a really loud round of applause from everybody that's out there.
Thank you so much. You guys have a wonderful day.
You too.